Hi, I'm Thomas Mitchell, and thank you for spending some time with me so that I can share some insights into the fascinating world of thoracic outlet syndrome. So, what is it? Well, the BMJ use the following diagnosis, which is a group of disorders that result in pain in the shoulder, the neck, due to compression of nerves or blood vessels below the neck. Okay, so this sounds pretty vague, eh? And as we can see, if we think about the symptoms, we're looking at pain in neck, shoulder, or arm. Sometimes I'll say the sides of the face or the head. Numbness or tingling in the arms or fingers, cold fingers or hands or arms. Also hyperhidrosis, so that can be excessive sweating in the hands. Muscle wasting, swelling in the hands, weakening grip, lack of colour, plus or minus trauma. So you can see all of these symptoms are things that we may associate with any number of pathologies in the upper limb, not just thoracic outlet syndrome. So there's a vagueness in terms of this. However, the core concept of thoracic outlet syndrome is neurovascular compression in the thoracic outlet. So we know that thoracic outlet syndrome is a rare condition. So that's 1 to 3 per 100,000 people. But that is not that rare. It's about as common as you may see Crohn's disease, or twice as common as you may find with ovarian cancer or thyroid cancer, which I'm sure you have patients or family members who maybe experienced these. I see a couple of cases per year in my private clinic, but I also have people coming to me for treatment because I've become a little bit recognised in terms of seeing and helping people with this condition. As well as this, I've picked up 2 in my first contact practitioner roles in primary care, where I'm working as part of a GP team. Now, interestingly, the least common is arterial, so that's fewer than 1 in 100 cases of thoracic outlet syndrome. But we also have the possibility of a mixed presentation. And a mixed presentation seems to make sense, doesn't it? Because the brachial plexus and the nerves of the brachial plexus run alongside the artery and nerve and venous tissue. So the idea that compression would be unique to one of those is possible, but it's also quite recognised that we can have mixed pictures of neural as well as vascular impediment. And I've decided to put these into 4 groupings. These are somatic referred differentials, neurogenic differentials, vascular differentials, and systematic differentials. So if we think about somatic referred pain, we have 2 causes of this. That's either musculoskeletal or visceral. So on a musculoskeletal point of view, cervical disc could cause pain coming into the arm, as could shoulder pathology referring down or up into the neck, as could cervical stenosis. And as I'm sure you're all aware, with visceral pathologies, something like angina can typically spread pain into the left arm, as could a Pancoast tumour in the apex of a lung, as could a heart attack. So all of these are things to be aware of if you're looking at a person who's presenting with these type of symptoms. When we hear hooves, think horses, not zebras. In terms of our neurogenic differentials, we can separate this into parasympathetic and sympathetic. If we return to our categories of possible differential diagnosis, it is clear that to identify thoracic outlet syndrome, the clinician needs to have musculoskeletal skills to examine the neck and the shoulder especially. The clinician also would benefit from good neurological examination to allow upper motor neuron, lower motor neuron, and sympathetic nervous system examination to help us identify neurogenic differential diagnoses. The points of compression of the subclavian axillary arterial complex are obviously in the scalenes, the subclavius or pec minor, or the first rib, or cervical rib if there is one present. Now, if we move on to venous occlusion of the structures in the thoracic outlet, this is more urgent, because what we're really talking about is a deep vein thrombosis of the nerves. And if it's a deep vein thrombosis of the subclavian artery, the subclavian axillary venous system, it's known as Paget-Schrotter syndrome. Okay, so Paget-Schrotter syndrome. And you can see here clearly in the picture the 3 points of compression, which can affect any of the areas for thoracic outlet syndrome, but especially neurogenic. That's the interscalene triangle, the costoclavicular space, and the coracopectoral triangle. Now, patients present with objective signs of nerve compression in true neurogenic thoracic outlet syndrome. So, true neurogenic is the easier form of neurogenic thoracic outlet to diagnose, because there will be muscle weakness, there will be atrophy, there will be a clearly identifiable cause of the compression in the vast majority of these cases. And that structure may be something like a cervical rib, or a fracture to the clavicle. And then we have our entrapment neuropathy tests. So these are provocative for symptoms, and we're using them to provoke symptoms. So remember that these are in our basic clinical radiculopathy, but we need to also be looking at our upper motor neuron testing and our lower motor neuron testing, and it helps us fill that clinical picture. The American Vascular Surgeon Association validate vascular palpation as one of the signs that help form a diagnosis of thoracic outlet syndrome. And for that, what they're looking at is two things. So that is unilateral symptom modification through palpations of the sternocleidomastoid and sternum and your pec minor, or severe pain with palpation of those areas unilaterally. So we're looking for a difference in either of those, and certainly this is something which I've used in patients to help me guide towards that triangulation of a diagnosis. And there's a useful PRM here, which we may use as a PRM to distinguish between cervical dysfunction and thoracic outlet symptoms. And this has some validation, and certainly if you're looking at doing a research project, this would be something I would consider using. So if we do suspect a person has thoracic outlet syndrome, what now? Well, talk with your colleagues, escalate up the chain. If you're in private practice, speaking with the GP. If you're in a hospital setting or a rehab setting, going through your seniors and your consultants. And again, nerve blocks would be recommended and can help confirm diagnosis and determine those who would benefit from surgical intervention. We also need to know referral pathways. So in the UK, it's the vascular surgeons who are the ones who have taken the lead, but there are also some orthopedic surgeons, shoulder specialists who are interested in this area. And it's possible as well that maybe neurologists are involved in this. So it's knowing who is your pathway. It's also possible that patients may want passive care or conservative care. So this is something that I'll discuss with a case study. And my case study features a patient who came to see me with suspected thoracic outlet system, but no clear diagnosis. Now, my cynical colleague Andrew Cuff said, "That's fine, Thomas. It's fine for you to say that this is a diagnosis where there is a lesion. But where are the placebo trials comparing patients who've had first rib removal with a placebo removal of the first rib, like they've done in the shoulder?" And I've got to say, he has got a point. There is no placebo-controlled trials looking at the surgical management of these cases. And everything is being done in a pragmatic, tacit-based learning experience. So, yeah, I find this an interesting area, and I find it a real lovely way of getting your clinical skills and your grey matter working to really help your patients. And, it's something where you can have long-term input with your patients and go on journeys and help them with shared decision-making to allow them to navigate their own management.
Watch the full-length masterclass for free on the Physiotutors app and enjoy more physiotherapy content tailored to your interests.